Video we are going to talk about a condition that is known as GEST. GEST is the gastrointestinal stromal tumor and actually the most common mesenchymal tumor of the abdomen. The name tells a lot about the disease. G, that stands for gastro, tells us that half of these tumors are located in stomach, that is the most common site of GEST. Intestinal are the other location of the GEST. Stromal term here is a misnomer because these tumors don't arise from the stroma, they arise from the interstitial cell of Cahal, the pacemaker cell of our GIT. Okay, and this is a mesenchymal tumor that we already know. Now, talking a little bit more about GEST, we need to know that there are few cases which may be clinically silent or precursor lesions of GEST. On having a loss or partial deletion of chromosome 9, 14, 22, we can manifest GEST, that is a overt GEST. Talking about little bit of APID, these occur generally in a patient who is 60 years old, okay, and the patient can present with a mass effect or pain, but the most common manifestation which the patient presents with is mucosal ulceration leading to blood loss and upper GI hemorrhage. Now, not 50% of patients with this blood loss will present with anemia and its sign and symptom. So this mucosal ulceration, blood loss and anemia, these are some common presentations seen in the patient with GEST. Or sometime doing a radiography or a surgical intervention for some other reason can give an incidental finding of GEST. Let's understand two types of the GEST, that is a familial variant and a sporadic variant. Note how sporadic variant is really common than the familial variant. Familial is also known as Carney-Stratakis syndrome, and this condition has a familial GEST and a paraganglioma. These two things are present in a familial GEST, whereas a case of a sporadic GEST is going to present with a triad. This triad consists itself of sporadic GEST, paraganglioma and pulmonary chondroma. So we will generally have a female who presents with paraganglioma, GEST and pulmonary chondromas. Note how this sporadic GEST is we are worried about because it is multifocal and really aggressive. Not only this, Carney's triad have SDH gene mutation and this makes treatment more difficult. We will study about it later. Let's look a bit into the pathology of the disease. So on a gross specimen, you are going to see a well circumscribed a fleshy mass that is well circumscribed, and most of the time we see a ulceration over it, that is ulceration over the mass that is of the GEST. Okay, on doing a histopath you will see two kind of cell here. Now we have one spindle cell, these are long cells and slender, and another plumpy cells which are epithelial like, that are epithelioid cell. The mixture of these two cells is what forms a GEST. Okay, talking about the spread, we already know this is a mesenchymal tumor and hence resembles a sarcoma and has hematogenous spread, and the most common side of the spread is our liver. Okay, we also need to differentiate when a GEST is benign or malignant, and this is done via a Fletcher classification. Fletcher classification uses two things to classify a tumor into benign or malignant, that is size of the tumor and number of mitotic figure, and this number of mitotic figure is the most common prognostic factor for a GEST. We have tried to understand a bit of demography and classification of GEST. Let's try to understand how we manage this disease. So managing this disease, we need to first identify it, and this is done via the radiological diagnosis, and the investigation of choice is always CECT in this case until we have a recurrent GEST or a metastatic GEST where the investigation of choice is PET-CT. Immunohistochemical markers are of much use in this case, and we need to remember every one of it because these have been asked a lot of time in exams. CD117 or c-KIT is the most common mutation seen in GEST. Around 75% of patients show this IHC in the when you do the test. Okay, another mutation is platelet derived growth factor receptor A, that is PDGFRA. These two are common mutations seen in GIST. Okay, when these two are absent, we look for a mitochondrial succinate dehydrogenase mutation, SDHABCD mutation. CD34 is another mutation that you must look for, seen in around 60 to 65% of cases. The most specific mutation in the case of GIST is the DOG1 mutation. Okay, so these are some important IHC, and after the diagnosis you go for the definitive management of disease, that is resecting this tumor with a 2 centimeter of margin. In case of stomach, you go for a wedge resection along with 2 centimeter of margin. If we have some structure that is adherent like peritoneum, you have to resect that structure too. Now talking about the lymph node, you never need to resect the lymph node in this case or clear the lymph node. This is because we already discussed this being a mesenchymal tumor is going to spread via hematogenous route. So no role of lymph node clearance here. In case we are looking into a case that is unresectable, a recurrent case, or a metastatic case, you need to give a tyrosine kinase inhibitor here, that is imatinib. In case we give imatinib here, in case we have a resistance, and here we study about the thing that we already know, that is Carney's trials had a SDH gene mutation. So in cases we give this therapy for long, we develop a resistance. Another scenario is when we have SDH gene mutation in Carney's triad here. So in these cases also we develop a resistance to imatinib, where we give sunitinib and sorafenib. This disease is not so common to say. In millions, around 100 of them develops in million. So this was bits about just you need to know. This is very important and high yield topic from examination point of view. Hope you liked it. Thanks for watching.